Good morning, dear colleagues. I'm going to speak about research and how can we find a bridge between clinical practice and research. I'm going to present you some research protocols that we are implemented, uh, that we implement and we have implemented in our private practice regarding the combination of modern pharmacotherapy and cognitive behavioral psychotherapy and rehabilitation. There are many meta-analysis, systematic reviews, and randomized controlled trials or non-randomized controlled trials, which are for us available and which prove the effectiveness and efficacy of this combination in mental health in the majority of the mental health disorders. So it is very easy when we citate these published research or studies. So we have chosen a difficult road to implement in our private practice our own research protocols because we want to see many factors. For example, if the combination is effective, what are the impression of the people who participate on our therapist, and uh, uh, possibly possible factors who play an important impact on the result, on the outcome of our therapies. So when we combine pharmacotherapy and psychotherapy, that means that we avoid polypharmacy, we avoid giving our patients a lot of agents, and we try to prescribe the most important so that psychotherapy can contribute uh, to the positive outcome of this combination. So we implement right now a research protocol regarding the combination of pharmacotherapy and individual cognitive behavioral psychotherapy by many mental health disorders, anxiety, depression, bipolar disorder, schizophrenia, and psychosis, obsessive compulsive disorder, PTSD, and personality disorders. We implement individual cognitive behavioral psychotherapy. And it is well known we want to discover if a long-term cognitive behavioral psychotherapy is possible and is effective. According to our experience, um, people uh, can end their own therapy after 50, 60, 70 sessions if they have comorbidities, depression with anxiety and personality disorder. When they suffer only from simple anxiety disorder, for example, only panic disorder, then it is clear that they can be cured after 10, 20 sessions. But the clinical praxis is much more complicated. And that's the reason we implement long-term therapies. But on the other side, it is clear that it makes no sense when we offer psychotherapies which last over 5 years or over 3 years. There is no there's no meta-analysis which proves that this is efficacious. Uh, this can a disadvantage. This can be a disadvantage because client and therapist can develop a dependent relationship, and that's not good for the therapy. So this research protocol regarding the combination of pharmacotherapy and individual cognitive behavioral psychotherapy is registered under clinical trials gov and will be implemented the next 2 years. I'm going to present you two more research protocols from our research group. So I'm going to share a PowerPoint. So yeah, this is a study that we implemented in 2025, between 2024 and 25. It is about the implementation of metacognitive training for depression in treatment-resistant depression with dependent personality disorder in a Greek sample. This is an unpublished research protocol. This is the first time we implement this therapy. Metacognitive training for depression was developed by Professor Lena Jelinek and Professor Stefan Moritz from the University of Hamburg in Germany. And I have translated the therapeutic slides for MCT, for depression in Greek. So depression is one of the most frequent mental health disorders in all over the world. Metacognitive training for depression is effective and efficacious. This research protocol aims to evaluate for the first time the effectiveness of metacognitive training for depression in a Greek sample. The main hypothesis is that this program will improve depression, anxiety, functional outcome, and recovery. And I have translated the MCT slides in Greek in collaboration with the colleagues in Hamburg. This is an unpublished protocol, but we comply with all ethical standards according to APA and Helsinki. The patients gave written informed consent for their involvement in this research project and for their oral presentation. The study population are outpatients which suffered from treatment-resistant depression and dependent personality disorder, and they were recruited by us in our private practice. Inclusion criteria is age between 18 and 60 in an ambulatory setting with psychiatric treatment and cognitive behavioral psychotherapy, and exclusion criteria were substance abuse, hospitalization, and age over 60. The antidepressant agents prescribed by Dr. Yurila were continued and stable during treatment and after therapy. This trial is a non-randomized trial. Patients were assigned to the therapy group after completing a baseline evaluation, and they were then assessed in post-therapy after 8 sessions of MCT regarding depression, anxiety, functional outcome, and recovery. I was a main therapist and Dr. Yurgila, the co-therapist. This research protocol evaluates only the outcome of depression. People who participate on this research protocol carry on with their therapy regarding the dependent personality disorder. But this research protocol focuses only on depression. We have a total sample of 25 patients with treatment-resistant depression and dependent personality disorder between September 24 and June 25, 3 groups with 6 patients and 1 group with 7 patients. So SEL90R and symptom rating scale for depression and anxiety as self-tests were administered to evaluate depression and anxiety. The Hamilton Depression Scale and the Montgomery and Asperger Depression Rating Scale were administered as clinician evaluation. Functional outcome was evaluated by who does, and recovery was evaluated through the Greek version of RAS-DS. All the tests were administered before the therapy and after the therapy by a blinded rater who has a Master of Science in Clinical Psychology. We have run statistical analysis with SPSS 13. A T-pair test was calculated. The effect sizes were also computed, and a simple regression analysis were also used. The middle of age is 36, 60% female, 80% unemployed, 40% married, 40% non-married, 20% divorced, and 92% non-dropout. We have only 8% of a dropout, a very small dropout. The T-pair test showed statistical significant results regarding depression and anxiety from the self-test and depression from the clinician evaluation. We have also statistical significant results regarding recovery and who does. Family status was significantly correlated with improvement of anxiety after treatment, with improvement of recovery after treatment, and with improvement of functional outcome after treatment. We have also run a simple regression analysis. 21% of the variance of depression and 12% of the variance on functional outcome can be explained through DMCT. We have calculated also effect sizes. The total therapy effect is 1.76. So a large effect size is due to the small sample. So DMCT was implemented for the first time in a Greek sample in a context of our private practice in Athens, Greece. DMCT is effective after 8 weekly sessions regarding depression, anxiety, functional outcome, and recovery. The total therapy effect size was 1.76. And the regression analysis showed that 21 of the variance of depression and 12% of the variance of functional outcome is explained through this therapy. Our study has the following disadvantages. The sample is small, it is not a randomized controlled trial, and there are no long-term follow-ups. But we have also advantages. This is the first study with a Greek sample regarding the implementation of TMCT in Greece. The dropout is small. DMCT improved depression, anxiety, recovery, and functional outcome. And DMCT was implemented for the first time in treatment-resistant depression with dependent personality disorders. Participants have expressed the following impressions. I have learned to cope with depression in a structured way. Cogito helps me via the exercises. Cogito is the app of metacognitive training, which can be downloaded in your mobile phone, and you can participate in many exercises after the therapy. I have learned a lot through the coping skills of the other participants in the group. This is um, a very positive outcome as a result of the group therapy. And further RCT studies with longer samples and longer follow-ups should be conducted in the future. Further studies regarding the effectiveness and efficacy of DMCT in treatment-resistant depression are necessary. So, thank you. And now I'm going to present you our two therapies, which were published by Springer Nature about, regarding the pharmacotherapy and psychotherapy of treatment-resistant schizophrenia and bipolar disorder. So this is our treatment-resistant schizophrenia manual, our recovery treatment-resistant GR. So treatment resistance in mental health disorders is determined by the following factors. The correct diagnosis was made, the appropriate treatment was proposed, but the treatment response remained inadequate. Treatment resistance can be primary or secondary. The switch to clozapine or a combination of clozapine and other antipsychotic medications presents the solution to the problem of TRS. Over 30% of individuals with schizophrenia belong to TRS. They show more deficits, cognitive deficits in executive functioning, general cognitive function, attention, working memory, information processing, speed, visual memory and learning, and especially in verbal memory and in language functions. Um, Patients with TRS have high rates of suicide, many comorbidities related to physical and mental health, frequent hospitalizations, and high rates of social isolation. Our recovery treatment-resistant ZR lasts about 190 sessions. We administer tests before the treatment regarding intelligence, cognition, psychopathology, recovery, and functional outcome. Then we begin with an introductory phase of 20 sessions. We make a restart in pharmacotherapy. Then we try to build a new therapeutic relationship, and we offer psychoeducation to patients and families. We speak about negative experience with past treatments, and we try to help the people to be assertive towards their own rights, even if they need legal help, legal procedures. Then we go to the second phase, which lasts 160 sessions. We have a cognitive phase, cognitive behavior psychotherapy for psychosis in 30 sessions according to Beck, and cognitive-oriented therapy in 70 sessions according to Beck are being implemented. Then we make a pause of 2 months, and then we go to the metacognitive phase in which group psychotherapy and rehabilitation are offered. The integrated psychological therapy, 50 sessions twice a week, and the metacognitive training for schizophrenia, 10 sessions twice a week are offered. The integrated psychological therapy was developed and co-developed by Professor Hans-Dieter Brenner, Volker Roda, and colleagues at the psychiatric unit of the University of Bern in Switzerland. and metacognitive training was developed by the research group of Stefan Moritz and colleagues at the University of Hamburg in Germany. Both therapies are efficacious and well known, so we're very glad that we have available so many effective treatments. Then we go to the third phase, which lasts 8 sessions, about 2 months. Relapse prevention and recovery as a process are the main issues. That means we discuss what has been improved, what not, what has to be changed, etc. And then we end the therapy with 2 monthly individual sessions and follow-ups. We administer the test after the therapy, and 6 months after the therapy, we have the possibility of repeating the therapy in case of relapse. So our recovery treatment-resistant DR will be compared with a control group in a randomized control trial, which is registered by clinical trials, and it is an ongoing trial between 25 and 27. We have implemented a pilot group, which proved that our program is effective regarding cognitive functions, psychopathology, recovery, and functional outcome. And here's an impression of a participant of our pilot group and a very good example of recovery in process. I wanted to die by suicide for many years. I have gone to numerous mental health experts who have prescribed many medications. I slept all day, and the rest of the day I smoked and consumed a lot of junk food. I was very desperate with respect to my life and daily routine. I attempted to find a job without success. A friend of mine who suffers from TRS has referred me to the experts. I met them in 3 sessions to arrange to clarify how recovery treatment-resistant TR can offer assistance to me. I decided to start with his therapy. I have learned what the issues of TRS are, why I took so numerous medications from past psychiatrists, why clozapine helped me, and how the absence of side effects of pharmacotherapy progressed my quality of life. Psychotherapy had shown me techniques to manage anxiety, depression, lack of motivation, coping with delusions and hallucinations. I'm very happy when I accomplish little objectives. I made follow-up sessions with the experts when I feel overpowered. I have moved forward my relationship with my family. And this is a non-randomized control trial, which was conducted between 22 and 24, and which evaluated the effectiveness and efficacy of the combination of IPT, metacognitive training, and pharmacotherapy. This is the metacognitive phase of our recovery treatment-resistant CR. And here we have the following results. The general linear model showed following statistical significant results: neurocognition, cognition, neurocognition, social cognition, psychopathology, functional outcome, recovery, etc. And then we focus on the 32 people with treatment-resistant schizophrenia. They have also statistical significant results in cognition, in psychopathology, in functional outcome, and recovery. Then we have conducted a regression analysis for the whole sample. Some of the results are the following. 54% of the variance of problem solving, 45% of the variance of negative symptoms, and 22% of the variance of total recovery can be explained through this combined treatment. And for the 32 people with treatment-resistant schizophrenia, we have the sum of the following results. 54% of the variance of verbal memory, and 41% of the variance of negative symptoms, and 25% of the total recovery can be explained through this combined treatment. So additionally, we have calculated effect sizes. We have a medium effect size of 0.72 for the total therapy effect, a medium effect size for cognition, for psychopathology, and a large effect size for functional outcome and recovery. When we focus only on the 32 people with treatment resistant, we have a medium effect size as total therapy effect size, a small effect size for cognition, and medium effect sizes for psychopathology, functional outcome, and recovery. So this is the second manual about treatment-resistant bipolar disorder published by Springer Nature last year. I want to thank Springer Nature for this wonderful cooperation, and especially Dr. Silvana Freidberg. Recovery treatment-resistant bipolar disorder, GR. So treatment-resistant bipolar disorder is characterized as a disappointment to attain symptomatic reduction for 8 weeks after 2 diverse medicines at satisfactory restorative dosages, with at least 2 monotherapy medicines, or at very least 1 monotherapy. Treatment-resistant bipolar disorder is associated with cognitive dysfunctions and a high suicidal risk. Treatment resistance arises in 20 to 60% of patients with mental health disorders. This is a very high percentage in mental health. So we need specialized treatments for treatment-resistant bipolar disorder. Our recovery treatment-resistant bipolar disorder lasts about 140 sessions. We administer the test before the treatment. Then we go to the introductory phase of 20 sessions. We make a restart with pharmacotherapy. We offer psychoeducation to patient and family. And we try to speak about negative experience with treatments in the past. Then we go to the second phase with 108 sessions. We begin with a cognitive phase, cognitive behavioral psychotherapy in an individual's context with 30 sessions. According to Beck, and cognitive-oriented therapy with 70 sessions in an individual context will be implemented. Then we make a pause of 2 months. And then we go to the metacognitive phase, in which group psychotherapy is offered, and especially the metacognitive training for bipolar disorder, 8 sessions once a week. Then we go to the third phase. We implement 8 sessions in 2 months in a context of an epilogue. Relapse prevention and recovery as a process are the main issues. And finally, 4 monthly individual sessions are being offered as follow-ups. We administer tests after the therapy, and 6 months after the therapy, we give the possibility of repeating the therapy in case of relapse, and we recommend cognitive behavioral coupled therapy after our program. And this is a feedback of a patient who participated in our pilot group, and a very good example of recovery process. I wanted to die by suicide for many years. I have gone to numerous mental health experts who have prescribed many medications. I slept all day. I was very desperate regarding my life and daily routine. I attempted to find a job without success. A friend of mine who suffers from treatment-resistant bipolar disorder has referred me to the experts. I met them in 5 sessions to arrange to clarify how this program can help me. I decided to start with this therapy. I have learned the problems of treatment-resistant bipolar disorder, why I took so numerous medications from past psychiatrists, and why clozapine and lithium helped me. I suffer from treatment-resistant bipolar disorder, and the balance regarding my pharmacotherapy depends on my adherence or compliance. I take my agents every day because I know why. Cognitive behavioral psychotherapy and metacognitive training had helped me manage my depressive and manic phases, and I contact with the experts if something changes for me. I control my psychopathology better. I have improved my relationship with my family. We spend a lot of time together without verbal abuse. I was attacked by my family in the past with verbal abuse. So I'm not the bipolar disorder. This is my disorder. So they have to respect that. I fight every day against treatment-resistant bipolar disorder. There is always a way to manage the negative consequences of a mental health disorder, and that's what I have learned with this program. Our recovery treatment-resistant bipolar disorder TR will be compared with the treatment as usual with the control group in this randomized controlled trial the next 2 years. Well, our programs have advantages and disadvantages. The disadvantages are that they are long-term treatments. Some patients and some experts cannot accept long-term treatments. They're not able to offer long-term treatments or to participate in long-term treatments. Intensive grief reactions after psychoeducation and awareness can be activated. This is a disadvantage in a short term, but can be an advantage in a long term because psychoeducation enhances compliance. The advantages are that we offer psychoeducation, evidence-based pharmacotherapy, evidence-based psychotherapy and rehabilitation. We avoid polypharmacy. Um, those programs are a democratic context. We spend a lot of time together, many hours, and we can discuss everything. Our very difficult issues, for example, when patients are confronted with many forms of abuse by the families or other people, or when they were confronted in the past with polypharmacy and many side effects uh, and organic problems, uh, or when they don't like something in our psychotherapy and pharmacotherapy. So we are open to discuss everything. Both of the programs are long-term treatments, and this is important and a very important issue for chronic mental health disorders such as treatment-resistant schizophrenia and bipolar disorder. They lead to recovery and resilience. So we dedicate our programs to all our patients who were treated and who are going to be treated with these programs, and especially to people who cannot have access to evidence-based therapies. Offering evidence-based treatments to scientific community is a kind of advocacy and to which we are all committed as mental health experts. The participation in an evidence-based treatment, and especially in the combination of individual and group therapies or treatments, is a participation in a social context, and this is a cornerstone of our democracy. So, so these are examples from the clinical practice and from our experience with mental health disorders. We are very happy to work in this context, and the combination of psychiatric treatment and intensive psychotherapy and rehabilitation is in favor of the patients and their families. We need specialized therapies, and we need experts who have clinical experience with mental health disorders. So there are no dead ends in our life. It is, we live today in 2025, and we're very lucky because we have many available effective treatments. Some things should be better. Some things should be improved regarding pharmacotherapy and psychotherapy, but available effective treatments are the reality. And these effective treatments contribute to the fact that people stay at home and they can treat it in an ambulant setting so that the reintegration into society can be easily. When we have an intensive ambulant treatment, we can avoid suicidality and long-term hospitalizations. Hospitalizations can be necessary and can be helpful, but the rule should be the ambulant intensive treatment. This is the modern clinical psychology and clinical psychiatry. So, through these research protocols, it was clear that the recovery process is a first priority for us. We have two kinds of recovery: recovery as an outcome, or objective recovery. This is the result of the test that we administer as mental health experts. We need objective results, or as objective as possible. And we need a combination of self-test and clinician evaluation tests. The other point of view is the recovery as a process. As you see, I have read a letter of the patients to recovery treatment-resistant GR and to recovery treatment-resistant bipolar disorder GR. This is a recovery as a process. This is how a patient or the consumer of the psychotherapy and pharmacotherapy describes his or her own progress and what has been improved and what not. This is a very important issue and a very important part when we give them the possibility to express their own point of view. They feel secure, they feel safe with us, and they are the protagonists of their own problems. They take an active role in their own problems. This is real democracy. Democracy in mental health. So the combination of recovery as an outcome and recovery as a process is something very important. And through these research protocols, you have seen that we focus on both of them. Mental health experts are not gods. We have the power to help people, but we have also the power to destroy people. So we have to hear the opinion of our clients and their families. And otherwise, we're not going to be sure if our therapy is effective or not. So we're very happy about these research protocols, and it is very important, especially for Greece, to implement those clinical trials. We have not so many published effectiveness and efficacy studies regarding the combination of pharmacotherapy and psychotherapy in Greece. So for us, it is very important to have an opportunity to implement such as research protocols and to publish, maybe to publish our results in the future. I have also experience with the implementation of group online cognitive behavioral psychotherapy by cystic fibrosis patients and caregivers, which is implemented by the Hellenic Cystic Fibrosis Association since 2022 until today. We have the Cystic Fibrosis Association organizes every year a conference, mostly at the end of the year, in which all the activities of this association is being presented, and the most modern evidence-based pharmacotherapies for cystic fibrosis patients. I have the opportunity during this conference to present results of this therapy, this group, cognitive behavior psychotherapy, which is online and which is offered once a year, was developed by myself with many, it is a combination of techniques of various techniques of the cognitive behavioral psychotherapy, and aims to improve, to reduce anxiety and depression, to improve assertiveness, functional outcome recovery, and we make also an introduction to grief. I have tried to publish the results of 2023 and 2024, and they are going to be published in the next months. Our paper is accepted for publication by the Journal of Rational Emotive Therapy and Cognitive Therapy. This is a very important journal for the cognitive behavioral psychotherapy family. So it is very important to combine in clinical practice the implementation of therapies and the research regarding their efficacy and effectiveness. So I hope that I have presented many information. If you have any questions, you can contact me. And I hope that if some of the colleagues are watching this video, I hope that other colleagues are going to take such as initiatives to combine clinical praxis and research. So have a nice day and take care.